Good afternoon, everyone. I'm so pleased to see so many people join this seminar. So I'm Lily Yao. I'm health economist working at University of Leicester, and I'm member of the intervention team for the multiple long-term condition working group. So today, our topic will focus on economic evaluation of long-term conditions. So I'm pleased to introduce our first speaker, Professor Luke Weil. Professor Weil is a professor of health economics at London School of Hygiene and Tropical Medicine. He is a member of the Global Health Economic Center, where there are over 100 academics and research staff. He is an international reputation in economic evaluation and health technology assessment, with extensive experience in design and conduct clinical trials and quasi-experimental and evidence synthesis. And today he will share his insights on the challenge for economic evaluation of long-term conditions. So please join me. Welcome, Professor Luke Weil.
So thank you very much for that, Lily. And I'll start off. Can I just double check? I just ask for a slide to be changed when I need to be changed, or do I have control?
If you say next slide, Luke, that's
okay. Thanks. Yeah, that's perfect. So if you go onto the topic slide, as Lily said, I'm sort of a health economist by background, and I work across a lot of different clinical areas, some of which are very closely or directly linked into multiple long-term conditions. And I'm trying to draw upon some of the examples of that in the talk today, and also thinking about some of the other sort of projects that I've done, which have got lessons to learn when I'm thinking about economic evaluations that might be conducted in this area. I'm not going to go through all the challenges. I'm going through ones that I thought would be maybe particularly interested. And I'm going to start off with the sort of idea that basically none of you have a good idea of what economic evaluation is. So apologies for some people, is that I'm going to be teaching you to suck eggs, at least for the first few slides. So apologies for that. So next slide, please. So I'm going to give a very brief summary about why we want to think about economic evaluation. I'm going to sort of introduce some of the different types of economic evaluation and what they try to do. And then I'm going to move on to the sort of the real meat of a sort of conversation, of a sort of presentation, which will take about half the presentation, which is some of the key issues to think about, and particularly when we're not just thinking about a healthcare setting, but actually a broader setting where we might be thinking about care and support for those with multiple long-term conditions. So next slide, please. So when I'm thinking about economic evaluation, I'm really being introduced in this area because we have a really big issue, a dilemma in sort of health services, healthcare, and care more generally, in that doesn't matter which country we're in, resources are scarce. We've always got limited resources. We can't do everything we want to do. And that means we're going to need to make choices about what to do and what not to do. And that means engaging in a process of priority setting. And that means thinking also about, well, where do we put our effort? And what would we give up by putting our effort in one way versus another way? And that gets us to think about what, for an economist, is the notion of cost, which is the idea about opportunity cost, which is the benefits we could have got had we used our limited resources in another desirable way. And economic evaluation is a way of providing information about opportunity costs to decision makers. So next slide, please. The broad aim of economic evaluation, health economics in general, is to try and add value to sort of some of the work that we're doing. It's not to make a decision. It's to help answer a question. So a lot of the situations where we're thinking about economic evaluation in particular, we're left to a point where we're trying to inform a judgment that a decision maker or a set of decision makers need to make about what to do, and so that they can make that judgment in a more relevant and informed way. So next slide, please. Economic evaluation itself, I've given you the technical definition on this slide, and really it's about the comparison of alternative ways of providing care for a given situation. And we want to think about that comparison, not just in terms of, say, their clinical effectiveness or their outcomes that it might give, but actually the resource consequences or the costs that might be involved in providing those different ways of care, and trying to equate them together to help inform judgments about which might be the best one to adopt in any given section. Now, there are a number of different types of economic evaluations, some of which I've presented here. And I'm going to talk about some of these in a little bit more detail, or at least allude to them. But the one that I'm going to, what's sort of highlighted in the green box, which I hope you can all see, is called cost utility analysis. And this is the mainstay of, I would say, decision making within the UK, and by healthcare organisations. So this is the approach that NICE in England are using when they're making an approach. It's the approach that the Scottish Medicines Consortium use in Scotland, and so on. And typically what it's trying to do is estimate the costs and the resource consequences of providing care, and estimate the health impacts of those and equate them against each other. And it uses, at least in a UK context, a very specific metric called the quality adjusted life year, which combines information on sort of length of life and quality of life together. And that's really useful in terms of being able to compare different healthcare interventions, some of which might have very different outcomes in terms of health. So you might be able to compare a treatment that might focus on heart disease to a treatment that might focus on cancers, and so on. And that's what NICE tries to do. And we will have some more sort of a discussion about outcome valuation in the next talk. But in this one, I'm going to be focusing a little bit about, well, it's good, it's useful, but it may not always be the best approach for consideration when we're thinking about multiple long-term conditions. So that's the different forms of economic evaluation. I'm now going to go on to just think about how economic evaluation brings together information on costs and consequences. So next slide, please. So this is a really sort of a diagram, a matrix about how we might think about costs and effects, or costs and benefits together, and what the decisions are that we might make. So if you consider, we've got two interventions, an experimental intervention and a control intervention. The experimental intervention could be one, more effective, two, of equal effectiveness, three, less effective, or we just don't know at this stage. Similarly, when it comes to costs, we could have the experimental intervention being less costly, as costly, or more costly than an experiment, than the control intervention, which might be current practice. And again, we might be in a situation where we don't know. So the best place to be on this matrix is area A1. So a new intervention is both more effective and less costly than an alternative. And in that situation, we unambiguously, from an economics point of view, recommend that intervention. There may be other reasons why we might choose, why we might not recommend the intervention, but from an economics point of view, we recommend that intervention. And the areas I've marked with a tick, which is A1, A2, and B1, we would recommend from an economics perspective, do the intervention. And the areas I've marked with a cross are areas where we would recommend we don't do the intervention. So the intervention, and those are areas B3, C2, and C3. And in those areas, the experimental intervention or the new intervention is unambiguously less efficient according to our criteria, and we'd recommend from an economics point of view not to do it. There's a bit in the middle, which is B2, where it could be either marked with a tick and a cross, and that means we have no meaningful differences in costs and effects, and we have no, from an economics side of view, we're indifferent about which points might be adopted, which options might be adopted. Now, there may be reasons other than economics to make a choice, but the economics is not helping that. More interesting, and perhaps the more common situation, is the areas where we've marked in red. And in those areas, we've got to make a judgment about whether or not a more costly option is worth the extra benefits that are provided. And that's in a situation where we start to present information around using a metric called the incremental cost effectiveness ratio, which is basically showing how much we have to spend to get one more unit of effectiveness, be it a QALY, a life, an extra year of life, or whatever we think is important. And most of the time, when we're thinking about new interventions, that's actually the situation we tend to be in. And a lot of the discussions around decision makers is whether or not the extra costs are actually going to be worth any extra benefits. And that's a bit that exercises organizations like NICE the most. So that's how we bring costs and benefits together. I've not really talked about the bit where we've got insufficient information, but to start off with, before we do any evaluations, we're probably lacking information about some degree of effectiveness or some degree of cost. But even after we've done an evaluation, we may lack information about one or more of those components. So we're in an area marked with a question mark. There, we might get into a situation where we explore, using the principles of economic evaluation, about how important that missing information might be. So at what magnitude might that missing information need to be to actually change a decision from one option to another? And is that plausible that that missing information could ever be that magnitude? So, for example, if I'm thinking about effectiveness, is it plausible that a new intervention could ever be that effective? And that might be just trying to inform and make judgments about whether or not that could ever happen. Now, that might be that the judgments that might be made might be, look, it's implausible, so let's not bother anymore. Or it's just so likely that we're confident that we can go for this option. Or more likely, we're going to need further research, and it needs to focus on at least demonstrating this difference in effectiveness. Okay, right. So I'm just going to quickly, if on the next slide, just introduce this idea about what a cost utility analysis might look like. So if we think about a healthcare program, a new way of providing care, what we want to think about is estimating resource use. So how much resources is going to be involved in providing that intervention, but also the consequences of providing that intervention in terms of future care. The impacts on health, how that impact on health might affect somebody's ability to work or well-being, the overall impact on total costs and on health outcomes, and drawing that comparison between the new way of providing care and the existing way of providing care to make some, or to inform some form of judgment. And every economic evaluation is more or less on the same way. It involves the idea of identifying, measuring and valuing both the costs and outcomes of alternative ways of providing treatment. So going back to that definition of Drummond and colleagues that I provided a few minutes ago. Right, next slide, please. So there you go. There's an MSc module's worth of health economics in about 10 minutes. Key points. So much for that. Let's go on to thinking about some of the key points. And I've just put a few on here that I'm going to cover in the next few minutes. So the first one, next slide, please. Our first question is really about being economic with economics. There's always an economic question, but it's not always necessary for an economic evaluation to answer it. And sometimes by thinking about an evaluation and thinking about what might happen, we can argue quite convincingly that if we can prove that something works, we don't need to go on to put in an extra effort to showing that it's efficient, because it is almost by definition going to be efficient. And there are certain circumstances where this might happen. So we have very, very low cost interventions. And that we can pretty much demonstrate that if it works, no outcomes will get worse as others get better. And there's no increases in particularly the need for costly long-term care that might occur. Now, this is so quite unlikely, perhaps, when the situation where we're thinking about multiple long-term conditions, but it could still be considered, because if we can avoid having to do an economic evaluation for sensible reasons, it makes everything else a lot easier in terms of carrying out an evaluation, because the economic evaluation adds extra cost, it adds complexity, it adds work. So anything we can do to avoid that in any form of valuation is a good thing. So that's the first point. Second one, please, next slide. Imagine now that we have decided that we want to perform an economic evaluation because it could add value. Now, the simplest and easiest form of economic evaluation is what's called a cost effectiveness analysis. And I introduced this on the earlier slide. And what happens in a cost effectiveness analysis is we equate costs against a single clinical or natural measure of effectiveness, like life years or differences in mortality. But it's unlikely that that single clinical measure is going to be fully capture the outcomes or the value of a treatment for someone who with multiple long-term conditions, because there are several things that are going on for that person. And there's likely to be trade-offs between outcomes. And if we're just focusing on health, this is what our metric, the quality adjusted life year, tries to capture. And it does that in various different ways, but it tries to capture different aspects in which an intervention might influence health, and then equate that in terms of what might happen in terms of life expectancy, and give me a single metric that I can use within the economic evaluation. What it's not good for, though, is it doesn't capture non-health outcomes. And that can be particularly of importance in some contexts of multiple long-term conditions, because some things like information or reassurance may not be really particularly well captured within that metric, or even captured at all. So we need to think about whether or not that's appropriate. Particularly also in multiple long-term conditions, we've got to think about, well, what are the impacts beyond the individual who has the multiple long-term condition? Because that person may be supported by those around them, carers, friends and relatives, and then maybe impacts on them that we also want to capture, particularly perhaps towards end of life might be a good example, and actually where there may be potential significant harms we might be causing to those around an individual because we don't provide the right sort of care or support to the person who's got the multiple long-term condition and those around them. So there's this issue about what is the outcome we might be measuring that we think is important, and how we might measure it. So if you go on to the next slide, please. Similarly, in terms of outcomes, not all the costs that we might be thinking about may fall on the health sector. So for multiple long-term conditions, we might be talking about social care as well as healthcare. We may also be thinking about costs that fall on carers, families and friends, because that will cause substantial hardship to those individuals potentially and possibly exacerbate inequalities. And key to actually thinking about all this is scoping out how an intervention may work and its impacts and outcomes. So many of you, I'm sure, will be familiar with the idea of thinking about multiple long-term conditions and the interventions for multiple long-term conditions as complex problems and complex interventions. And in that circumstance, you might be thinking about developing a logic or a theory of change model about how an intervention might use. And it's perfectly appropriate, in fact, or I would say arguably essential, that you put an economics perspective into that and think about how that might, what the impacts and outcomes of an intervention might be from an economic side, as well as all the other components that you might be thinking about. And on the next slide, I just show a different example of that. And so this is an example of a particular logic model, and I'm sorry it's quite small, but obviously the slides will be changed, that was developed for an evaluation looking at how to help support individuals who've got multiple long-term conditions maintain a place in the labour market, maintain employment when they're able to. And it was thinking about how we might measure some of these aspects, what sort of these aspects might be, and how they might bounce through and affect different sorts of outcomes. Now, we can think about this in terms of more complicated logic models if we so wished, but the key component is to think of it as a logic model. And so for each outcome, economics outcome and all outcomes that we can think about, we could think about how we might measure those outcomes, how we might value those outcomes, and how those in the analysis plans might be combined. Next slide, please. Final sort of issue that I want to cover before coming up like a practical consideration is who's the decision maker. And I'm focusing on this primarily because we want to tailor the work that we produce to the needs of the decision makers. And it's not a one size fits all. My typical framework that I might be using in economic evaluation, this presentation of a cost per quality model, really fits some of the NHS decision-making and NICE decision-making frameworks, but it might not fit all the other different frameworks that might be. So I'm going to give you an example. If I was a local authority with responsible for adult social care provision, what framework should I use? I might choose to use a different framework and use something that actually is more familiar to their decision-making context. So if you give me the next slide, please. So I'm giving an example here. So this isn't necessarily a multiple long-term condition particularly, but it's about how we might change. So this is a project that's been carried out, obviously, in Newcastle and Gateshead, about improving the housing stock for people and social housing stock. And it's primarily focusing on those who may have multiple long-term conditions and thinking about how we might make the properties more energy efficient, but also not causing harms in terms of changing their indoor air quality. And so there's pros and cons to what we're doing, but the decision maker here is a council. It's a council's funds in terms of thinking about should they invest in this area. And what is it that they really needed to know? So we can evaluate cost effectiveness, but we're also using a different tool called social return on investment of an intervention. And why we're using that is because that starts to use a metric that the local authorities are more familiar with using with. It's something they think about for some of their other decisions that they're using. So it's trying to use that same idea. So next slide, please. So on this slide, all I'm trying to talk about or introduce is thinking about some of the information that was being detected or worked on through there. So There's nothing particularly special in there. It's worked through all the different aspects that thought might be relevant to when we're improving the housing stock in a particular area and thinking about their impacts on health and beyond health, including, for example, how much people are spending on fuel, so that we're trying to alleviate fuel poverty, which will have knock-on effects on people's health and well-being. I'm trying to present that in this overall economic output impact of social return on investment. So next slide, please. And what we're trying to do here is using that terminology that's familiar to those local investments, because they're thinking about return on investments type approaches when they think about everything else. And this actual approach really is a part of, or fits very closely to one of the other forms of economic evaluation, which is really common in every other sector of the economy apart from healthcare, which is called cost-benefit analysis. And it's helpful to help think about very disparate impacts into a single analysis. But using this approach allows me to tailor analysis in different ways and present it in different ways for different types of decision maker or different stakeholders, but also to explore different trade-offs, because different stakeholders will want the information in different ways. So if there was a health decision maker in all this, I'm absolutely certain they would probably also want to know something about, for example, the incremental cost per QALY, because that's often the metric that they're using. So next slide, please. Next one here is just an issue about economic evaluation and its complexity. So basically, don't get worried about economic evaluations being complex. Complexity is not a good thing or a bad thing per se, but it's helpful. I would argue that it's helpful to be complex when we're thinking about the design and conceptualization of any study, and then we try and draw it back into the simplest way possible when we're presenting the information, finally, to the different decision makers and stakeholders. And then also thinking about actually, how is it those stakeholders would really like the information presented to them? And that's a way of actually also bringing in those stakeholders into a form of co-design of the economic evaluation itself and the way that economic evaluation itself is going to be presented so that they have the buy-in into the whole process. Final slide, I think you'll be glad to know. I think that is practical considerations in all this. Engage with a health economist early. Think about it right at the start, the study design stage. Piggybacking can be done, but it's severely limited, so embed from the start. Don't assume that there's a one-size-fits-all. Tailor whatever you do to the question. And I do have one more slide, which is just a summary slide, I think, which is my take-home messages. And I'm only going to say one word on that. Think early, think often. Don't fall into the trap that Martin Buxkin, who is one of my now retired colleagues in health economics, mentioned, is it's always too early for economic evaluation until it's too late.
Thank you so much, Luke. That's excellent presentation. So we have 3 minutes for question. So feel free to use the chat to raise your questions. So I got 2 excellent questions. And Luke, I will read it for you. So how do we combine the health and social care economic perspective to meet the need of new integrated neighborhood initiative? I think this is a very challenging question.
So that actually is a really good one, and it focuses quite closely onto the idea of sort of the into-air example is, well, what is it we hope that those preventative initiatives will actually achieve? What's the mechanism by which we think they can act? What's the outcomes and impacts that we think that they may produce? So very early on, starting about defining the theory of change or the logic about how that works. If we can do that, then we can identify the sets of information that we need to collect or assemble from elsewhere. And from there, we can start to think about the optimal way of thinking about the analysis. So I would probably start from thinking of it as if it was going to be a cost-benefit analysis and try and simplify it as quickly as possible where I can, because I can rule out certain issues of being of importance.
That's very good answer. So I have time for another question. So how do we handle the potentially long-term horizons for economic evaluation that preventive initiative?
So that's a very common issue in all economic evaluations is how to think about the long term. And typically we will need to try and capture and model the long-term impacts. And how we model the long-term impacts is typically think about borrowing data from multiple other sources to try and make estimates. It's always a key part. I do a lot of work for, or have done a lot of work for NICE looking at new drugs, new technologies, and it's always a key issue about what the long-term impacts are. But we can start to explore how those are. Perhaps the more challenging in some of these areas here is where we might have intergenerational effects.
So thank you, Luke. So thank you, Luke. So we still have few more questions. If you can answer them over the chat. Now we're moving to welcome our second speaker. So our second speaker is Dr. Shad Whalen. So Shad Whalen is a senior associate researcher working at University of Leicester in my team. And she is a health economist with experience across academy and the NHS and also consultancy. She previously worked as a researcher at University of Oxford. She is also a technical lead in consultancy, where she led modeling development and evidence synthesis supporting HTA submissions. So Shad completed her PhD at UCL and now working in my group. Now welcome Dr. Shad Whalen. And her topic is EQ5D, the health-related quality of life. And she will use one of 4 projects to illustrate the measurement of quality life. Now, welcome, Dr. Shad Whalen.
Thank you very much, Lily. So as Lily mentioned, the topic of my title is EQ5D, health-related quality of life, as well as the REDUCE study. Next slide, please. So today is a very quick practical tour of health utilities. So the kind of one number quality of life measure that health economists use to compare value across different health conditions. We'll first start with the big idea, so utilities and qualities. Then we'll zoom in on the EQ5D because it's short, widely used, and it produces preference-based utilities. Then I will show how to read the 5-digit codes and avoid common mistakes that a lot of people can make. Then we'll mention the EQ5D profile and how they become utilities through a country-specific value set, which is also called the tariff. Once we have utilities over time, we can calculate the qualities using the area under the curve approach. And then we will finally use the REDUCE study as a real case study. So briefly, the REDUCE study evaluated internet and telephone interventions to support people discontinuing long-term antidepressants in primary care, and it basically reported clinical outcomes and cost utility analyses. Next slide, please. So why measure utilities? So utilities are a way to express health-related quality of life, which Luke previously mentioned in the slides. So it's on a preference-based scale. So 1 usually means full health, and 0 is equivalent to death. And some states can be valued below 0 when people judge them as worse than actual death. Once we have a utility, qualities are straightforward in principle. So you have utilities multiplied by time. So 1 year in utility of, say, 0.8 is 0.8 quality. 2 years, for example, at 0.5 is 1 quality. So in practice, people's utility changes over time, so we don't assume it's constant because people feel differently over time. We measure utility at multiple time points, then calculate an average utility over follow-up time using the area under the curve. The reason this matters is when healthcare budgets are finite, cost utility or cost effectiveness analysis ask how much health gain do we buy per pound spent. Next slide, please. So what is EQ5D? As we mentioned, it's a short generic questionnaire that can generate utilities. It is developed by the Euroqual group. It asks people to describe their health across 5 different dimensions. But first one, and always has to be in order, mobility, then self-care, then usual activities, then pain and discomfort, and then anxiety and depression. So an example of mobility would be people the ability to walk and move about, physical movement capabilities, freedom of physical activity. Examples of the self-care would be washing your hands, bathing abilities, dressing and grooming tasks, personal hygiene maintenance. The usual activities include work and employment tasks, leisure and hobby pursuits, daily routine principles. Pain and discomfort is how much people are experiencing pain and discomfort in their everyday lives. Anxiety includes feeling worried, afraid, low mood, sadness, depression, as well as emotional distress that can affect their well-being. Next slide, please. Sorry. So there are 2 versions of the EQ5D. So we have the 5 level, which includes no problems, slight problems, moderate problems, severe problems, and extremely unable problems. So in the older 3L version, there are only 3 levels, so it includes no problem, some problem, and extreme problems. When we choose one level in each of the 5 dimensions or in the 3 dimensions, we end up with a 5, well, actually, no, in the 5 dimension, we end up with a 5 digit, so health state code. That's the descriptive profile. For example, if we have 13315, it means no problem mobility. Again, it has to be in order. Moderate problems with self-care and usual activities, no pain or discomfort, and extreme anxiety, depression. So 5 is the highest number, so it's always extreme. The number of possible states follows from basic counting. In 5 dimensions, each having 5 levels, you have 5 to the power of 5, or 3,123 possible states. So the extra details are why the 5L can be more sensitive than the 3L, because it asks more about the severity level or discomfort level of patients or people answering the questionnaire. In the next couple of slides, we'll practice reading the codes with the highlight, and as well as highlight things that we don't do when calculating it. Next slide, please. So dimensions and levels of the 5L, how to interpret the 5-digit code. So it goes from level 1 to 5 severity. Unable to walk is always extreme level, so it has a score of 5. So when we see a code like 1111, that means that there's no problems at all in all dimensions. But when we see a code like a 5555, it means that there's an extreme unable across all dimensions. There are 2 practical reminders. So 1, the code is descriptive, not an actual score. It tells us where the problems are, and the meaning depends on the order. So a 5 in the first digit is a mobility issue. A 5 in the last digit is an extreme anxiety depression. So just kind of to state it again. Next slide, please. So let's practice with an example code. We have 13315. The first digit includes mobility, so 1 means no problem walking about. And we'll just skip to the last one of 5, means extreme anxiety or depression. So what's useful here is that the pattern, someone can have good physical mobility and no pain, but still have serious issues in mental health. When we report the EQ5D descriptively, we typically talk about the distribution of problems by dimension. So what % of people report no problems in anxiety? Next slide, please. Here is a more extreme example of 53342. The person is unable to walk about, has moderate problems with self-care and usual activities, severe pain, discomfort, or only slight anxiety, depression. When we calculate this, when we look at this, we do not add the digits together to make a score because that would be incorrect. The EQ5D numbers aren't meant to be added, so doing that would just make the results meaningless. So a 5 in mobility is not the same kind of thing as a 5 in anxiety or depression, and where the problem is matters clinically. So we need to report how many people fall. So from this code, we need to report how many people fall into each level, track how these levels change over time, and if we need one number, then we convert the EQ5D profile into a utility score using the country's value set. That's what allows the quality calculations. Next slide, please. So again, the 5 digits only describe health. To get a utility score, we apply a country's value set. So each country has its own value set. So the same EQ5D profile can have different results or utility scores in different places or different countries. Usually different countries, actually. Next slide, please. When completing the EQ5D, we also have a 0 to 100 health rating scale, also called the EQ-VAS. It's useful for describing health, but it's not measured for qualities. If you need to compare results across countries, the right approach is to take the original EQ5D profile and rescore them using the other country's value set rather than trying to convert one utility score into another. Next slide, please. Next slide, please. Sorry. So once we have utilities, qualities are basically utilities times time. But the key thing is that utility often changes over follow-ups. Instead of assuming utility is constant, as we mentioned previously, we typically calculate the qualities using the area under the curve approach. Utility is on the y-axis, and time is on the x-axis. The area under that curve over the follow-up period is the total qualities. In practice, we don't have continuous utility because, again, people feel differently over time. We have measurements at discrete time points. In the reduced study, they measure qualities repeatedly and then calculate qualities over a 12 months time period using this method. Next slide, please. The EQ5D is not the only option to use, but it's a standard for generating utilities and qualities. There are other utility measures, such as the SF36 and the SF12. They tell you a lot about someone's health, but they don't produce a utility score on their own. To use them for qualities, we usually need to convert them using separate scoring methods. Some studies can use both, so the EQ5D and the SF36 or the 12. The SF measures have richer clinical sensitivity, and the SF36 has basically 8 dimensions, looking at physical functioning, role physical, limitations due to physical health, bodily pain, general health, social functioning, and mental health. Other generic tools exist, such as the HUY and disease-specific measures, can be more sensitive but not comparable across diseases as we have for the EQ5D. Next slide, please. So, reduce. What is it and why was it needed? It tests or assesses the long-term antidepressant use and has increased significantly, mainly because people stay on treatment for a much longer period. Some of the reasons why it had barriers to stopping it was people were afraid of having a relapse, withdrawal of symptoms, fewer medication reviews over time, which means fewer chances to reassess the need. So overall, the aim of the study was to support safe, appropriate discontinuation of long-term antidepressants without worsening depression and evaluate whether the approach is cost-effective. The reduced intervention had 3 parts. First is the advisor for the patients. So it was an online tailored support for patients. The advisor HP clinicians, which was practitioner-focused online guidance and specific tools for that. And then telephone support, which was you basically get 3 calls from psychiatrists, and then they look at their well-being as well as practitioners. So while the combination matters, it expands support beyond standard GP appointments, and it still maintains clinical oversight. Slide, please. So how Reduce was designed, so there was a large collaboration, co-production across several universities and team members. It was led by health psychologists with input from GPs, psychiatrists, sociologists, pharmacists, and PPI contributors. And it was built through strong collaboration across UK universities, NHS team, and trial units. So we got a broad range of different opinions and views on it from different team members. So again, it was to create something that genuinely works in everyday primary care and tested appropriately. Next slide, please. How utilities and qualities were measured. So it was measured purely with the EQ5G5L plus the SF12 utilities for comparison. It repeated measures captured short-term withdrawal effects using for the economic steps, it converted EQ5G profiles to utilities. It mapped utilities over time, so 12 months time period, and it combined costs and qualities to generate the ICERs. Uncertainty within the study was handled with bootstrapping, multiple imputations, and the cost effectiveness analysis for willingness to pay threshold. And clinical outcomes show if it works, quality show if it's worth scaling or not. Next slide, please. So results showed that clinically the intervention performs safely and at least as well as usual care. The PHQ-9 score, which is a short non-questionnaire screening tool, can be used by clinicians to assess symptoms of depression and how severe they may be, was also used. And it was within the results, it was 1 point lower in the intervention group, which was small but still in the right direction. Discontinuation rates were similar between the groups. The clear benefits were fewer withdrawal symptoms and slightly better well-being over 12 months time period. There were no harms or negative effects that were seen on anxiety, quality of life, or satisfaction. So overall results showed that it was safe, stable outcomes with good improvements where it was observed. Next slide, please. So economically, the intervention had good value. There was a small quality gain and a small cost saving, giving negative ICER, meaning it's dominant. Sensitivity analysis still show it remains cost effective. And in simple terms, it was slightly better outcomes, slightly lower cost, but it was worth the funding.